This is an ultrasound study of a patient aged 20 years, referred with the history of pyuria, painless for the last few months, not responding to any antibiotic whatsoever. Now the picture in front of you shows, first of all, if we concentrate on the liver, then we see that the liver shows diffuse decreased parenchymal echogenicity to the extent that the minor portal vein radicals are so prominent. You see, these are all minor portal vein radicals. This is the hemidiaphragm right, this is the right kidney. Now you see there is dense shadowing seen above the diaphragm, which is suggestive of some pulmonary pathology or cardiac pathology. However, first of all, let's see now the status of the kidney. The kidney shows mild hydronephrosis. You see all the calyces are dilated minimally and better curvature lower side. Curvature Q. Okay, now this is the kidney, and the kidney shows only minimal hydronephrosis, whereas its dimensions are normal. And these are the dilated calyces. Dimensions are normal. Corticomedullary differentiation is intact. No calculus is seen, and thoda sa beta bas. Otherwise, the kidney is normal, except that there is minimal hydronephrosis seen. Now, this is small, very small amount of fluid seen above the diaphragm with this starry appearing liver above it. So this is the status here. See the ojopeta. There is no evidence of intrahepatic, para-aortic plane adenopathy. As you can see that this is the aorta, and you can see the superior mesenteric artery arising from it. This is the proximal aorta, superior mesenteric artery, celiac axis, and well, this is the view of the pancreas with both kidneys in transfer section. You see, this is the pancreas, the splenic vein, superior mesenteric vein, the aorta, the IVC. This is the aorta, superior mesenteric vein, and there is no finding related to this area. Rules out adenopathy. This is the spleen, and the spleen is normal in dimension. This is the left kidney, and in the left kidney again we see only minimal hydronephrosis with normal dimensions and intact corticomedullary differentiation, as well as the parenchymal echogenicity is normal, parenchymal thickness is normal, no calculus is seen in this kidney. See there shown. Now, having seen all this, एक लंबा सा लो बेटा, जोर से रोक लो, लंबा सा लेके सा रोक. Now, okay, I want to show you the liver in total, so as you can make up that the toxic liver appears as we are seeing here. You see the toxicity of the liver. Why I'll say this, that it is a toxic liver? Because of the starry appearance of the liver parenchyma, because of prominence of the pyramids, and another factor is that you can see that there is raised periportal echoes. Periportal echoes are significantly raised, and the diaphragm appears more thick as compared to the normal. This diaphragm is thicker than as we see in normal cases. That's why I repeatedly say that the as perfect as normal in normal study. This is the posterior branch of from the right portal vein. See the echogenic border around it. It is increased. So the increased echogenicity of the periportal echoes, and however there is एक बेटा लंबा सांस लेके सांस रोको जितना दूर है लंबा सांस गॉल ब्लैडर इज नॉर्मल बस ठीक है सांस ले लो The IVC is not dilated, intrahepatic vessels are not dilated, so this is not a congestive liver, this is basically a toxic infective liver. Come down to the pelvis, we see that there is, now this is a post-micturiation bladder. Patient has I had tried to get her bladder empty twice, but this is the post-void residual volume as it is in front of us, and you can see there is a lot of debris. These echoes are suggestive of debris, and these echoes are suggestive of debris. This is the longitudinal section of the urinary bladder, the transverse section of the urinary bladder, and the calculated post-micturation residual volume is approximately 102 100 ml per 100 cc is the post-micturation residual volume in this young boy. Now you see there is ascites, you can see free fluid. This is the free fluid, and you will see bowels floating in it. This is the urinary bladder. Let me magnify it to make it clear to you. You can see the fluid in longitudinal section with bowels floating in the ascitic fluid. This is the urinary bladder, and this is the ascitic fluid seen minimal in amount in the dependent region peritoneal cavity. This is the free fluid. This ascitic fluid in this 20 years young boy. Okay, now see the wall of the urinary bladder. Now this is again, this part of it shows you ascites again. This is the urinary bladder. Note the walls of the urinary bladder. I am manipulating with the knobs to show you. See the hypertrophic trabeculation of the walls. This you see, this is the anterior wall. It's not thick, and this is the right lateral wall, and you can see it's not. It should have been. We should have seen it like this, thin, but this is not thin. It has echogenic areas around it. The bulbous cystitis that we call as with debris in its dependent portion. This is the ascitic fluid. And what about the left wall? In the left wall shows all the same findings that we see on the right side. Hypertrophic trabeculae or bulbous cystitis, as you may call it. This is the right temporal wall. See the hypertrophic trabeculae or bulbous cystitis with ascitic fluid. See posterior to it. This is the ascitic fluid. See posterior. So this is in fact a case of tuberculosis tuberculosis of the genitourinary organ as a cause of his pyuria not responding to any other antibiotic, and walls of the urinary bladder appear thick, post-micturation residual volume is raised, all because of the cystitis, bulbous cystitis, which, if I can show you, This is the bulbous cystitis. This is our case of the day. Thank you very much.